Welcome, everybody. We're really sorry we're having some kind of technical problems. And I guess that we've had them in our last sessions also. But sorry, we're here. We're just missing one of the panelists. Hopefully, she'll be able to join shortly. My name is Florencia. I'm the Regional Program Director for Glasswing, and thank you for attending this session. We're going to talk about, we're going to be exploring the disparities in mental health access in rural and urban communities. But first of all, I want to introduce my panelists. I want them to tell you a little bit about themselves. So please, Rachel, do you want to start?
Sure. Thank you, Florencia. It's such a pleasure to be here. And hello, Anna and Michelle. I'm looking forward to Gisela being able to join us too. My name is Rachel Cadell-Monroe, and I'm the Executive Director of Sea Change Initiative, which is an organization which works with communities to develop a community-first response to health crises. I formerly worked with Médecins Sans Frontières, Doctors Without Borders, and have been a humanitarian worker for most of my professional life. And I'm very pleased to be here.
Thank you, Rachel. Michelle?
Thank you. It's a pleasure to be here and really looking forward to our discussion today. I am Michelle Cruikshank. I'm based in Toronto and am representing Grand Challenges Canada today. I am the Senior Portfolio Manager for our Global Mental Health Portfolio. We work across over 40 countries in low and middle income countries, working to support innovation in mental health. So it's great to be here today.
Great. Thank you, Michelle. Anna?
Hi, everyone. Thank you. I'm really glad to be here as well. My name is Ana Beatriz Elcadri. I'm based in Brazil, and I'm coordinator of projects at Nossas, specifically of Mapa do Acolhimento, which is a project that connects women who have suffered gender-based violence with psychologists and lawyers that provide services voluntarily. And I'm really glad to be here. I'm specialized in attending women who have suffered gender-based violence. And I'm really looking forward for our panel today.
Thank you, Anna. Impressive women we have here. Okay, so we're going to talk about a little bit about the access to mental health in rural communities. I mean, in the past couple of years, mental health has been somewhat more in the spotlight than before, especially because of COVID, right? And there's also a shift to mental health as a state of well-being, aside from mental health from a kind of illness or a condition, right? And in previous sessions, we've heard a lot about different interventions that have been implemented in different countries and different approaches. And we know from many investigations that the need and the demand for mental health care is mostly the same in rural and urban areas. But what happens if these services are unavailable or unaffordable or inaccessible for people living in these rural communities, especially indigenous communities or communities where they are more vulnerable? Right? So I wanted to start with Gisela, asking her about her community, but she's not here right now. So we're going to start with Rachel. I wanted to ask you, Rachel, we have a lot of humanitarian crisis, and we know that rural communities are basically most vulnerable in these moments. How can we intervene, or how can we respond to mental health during this crisis?
Yeah, thanks for the question, Florencia. I don't know, I'm hearing a lot of echoes, but maybe good if Anna and Susan, you're able to mute for while we're talking. Yeah, thank you for the, still hearing a lot of echo. I don't know, Anna, would you be able to mute?
Sorry.
No problem. That's better. It may be better for the audience as well. So yeah, thank you for the question. So what we've found is that in humanitarian response, probably not enough attention is paid to the mental health situation of the populations. You know, we understand that when we go into a crisis situation, that people are suffering and it's difficult, but we go very much for this very immediate response and the kind of the dealing with the physical and practical issues around it, and often not talking about mental health at the beginning. And what I've realized is that, you know, more and more over the years that there is a massive importance of having a kind of trauma-informed approach when we're dealing with humanitarian crisis response, and really understanding what does that mean and how does that impact the population as that humanitarian crisis response is being developed. So I wanted to give a really concrete example, and I hope Gisela is going to come in because she's going to talk about her community's mental health approaches that they used in Honduras. But I've been working a lot with the Inuit populations in the north of Canada. So right far up in the north of Canada, we have populations around 35,000 people living in a territory called Nunavut. And these Inuit have been victims of decades of colonization and racist policies, particularly around healthcare, but around many different issues. And this has led to desperately poor living conditions, very low employment, and many social problems in the communities. But these are problems that have a long story behind them. At the same time, we see really serious health issues happening. So I started working with them because they had an outbreak of tuberculosis, and actually it's an epidemic of tuberculosis that's been going on for decades in the north of Canada. Inuit people today are 300 times more likely to suffer from tuberculosis than any Canadian-born non-Indigenous person. And tuberculosis is a very old disease. Many of you will know it from working in other parts of the world. And it's very easily treatable, not so much for the multi-drug resistant TB, which is more complex, but this is simple TB. It's not complex TB. So we have all the medications available in Canada, yet people are still dying, getting sick from it, whereas people who live in the south are not. And this is very much explained by the history of tuberculosis with these people. In the 1950s and 60s, when the Canadian government realized that many people were suffering from TB there, they sent out big ships up into the north of Canada and forcefully put people onto those ships for treatment in the south of Canada. And those people, they didn't speak English. The health staff didn't speak Inuktitut, their indigenous language. They came down not knowing what was happening to them, not knowing what TB was. And they were put in sanatoriums in the south around Toronto, Ottawa, Montreal, and also further west, where they were extremely badly treated. And there are terrible stories of what happened to them in those TB facilities. Many of them never returned to their families. Their families never knew where they were. Some of them returned after 2, 3, 4 years in these sanatoriums, having forgotten how to speak Inuktitut, having learned different ways of living, and then were just sent back to these communities where their families often rejected them because they were no longer the same as the other people in their communities. So if we want to deal with TB today, we have to understand that history, we have to understand what's going on with those people. And so we're working with an Indigenous organization, Inuit-led organization, who have been working on a mental health, trauma-informed approach to issues that are going on inside their community. And what we're doing now is taking the experiences that they have as an Indigenous community and using those to apply it to tuberculosis. So we hold trauma-informed workshops with the community, and it starts with a few days of people just being able to share their experiences, their memories, what happened to them, because we have to remember that this trauma is also intergenerational. So the grandparents received that, were the ones who suffered in those sanatoriums, but then their daughters and their sons suffer, and then their grandchildren suffer, and their great-grandchildren suffer, because that abuse, the cycle of abuse, continues and doesn't get broken. So what we're trying to do now is break that cycle of abuse and use that discussion of what tuberculosis has meant in those communities, the history that they've gone through, for people to understand why they were taken away from their homes, what happened to them, what tuberculosis is, and then now how they can change their approach to it. So not only do we try to then, with the community members, become champions of how to prevent and do early diagnosis of tuberculosis in their community, but they're also breaking that cycle of abuse in their community. So this is one of the very practical ways that we've been applying that trauma-informed approach.
Thank you, Rachel. Wow, that's so interesting. And I'm going to come back to you to talk a little bit about how communities can come together in a trauma-informed way to heal from traumatic situations like these. And I guess that one of the most traumatic situations is gender-based violence, right, Anna? It's something that our communities are living every day. And how do we deal with this in rural communities? What are the challenges for women to access mental health services? Are there any, or what's going on?
I think it's, for starters, it's important to say that Brazil, which is our experience in working with gender-based violence in NOSAS, it's a continuation, extension, and extremely unequal country. So when we are talking about Brazil, we are talking about 5,000 municipalities. So when we are talking about the settings between the access to mental health services to rural and urban communities, there is a great discrepancy between the distribution of access to mental health support. And as we've seen in the work with NOSAS, providing mental health to women who have suffered gender-based violence through a volunteer network of professionals, we see that mental health support, it's used actually to address the trauma, as Rachel was saying, caused by this kind of violence. So they use the mental health support to gain their confidence back, to try to rebuild their lives. So that is a kind of services that is really important. But the issue about it is that not every communities have the access provided by the government through public policies. When we are talking about mental health support to women who have suffered gender-based violence, it's necessary to consider their specificities from an intersectional perspective, and the different kind of women and their different kind of realities. As Black women, riverine women, indigenous women, we have all these social groups in Brazil that are suffer gender-based violence, but in different kind of ways. So the public policies need to address their demands in different ways. But when we are talking about these communities specifically, they are the most affected by mental health issues, not only considering the gender-based violence, because they are the communities that are most likely to suffer gender-based violence, but because they don't have access to basic services to guarantee their survival. So this is an issue because the governments do not invest in these kinds of public policies. We have a few specific services in our network of public services that provide mental health support. They count with mental health professionals there, but this kind of service, this kind of specific services that count with this kind of support, they are located on the wealthier areas of the country with greater access, and they are located in the urban centers. So the communities that are far from their urban centers, as the indigenous, Black women, and riverine women, they don't have this kind of access. And this lack of access to this kind of public policy, it's due the government's investment, the lack of government investment in this kind of areas. Because in Brazil, we don't have this culture that values mental health support. We don't have this kind of, that it's not something that is directed to the general population. So when we are talking about public policies and who is thinking about how to build this public policy, this is not a priority. So there are no centers that offer mental health services in the cities of this kind of communities. So this generates some main barriers because, for example, a woman who lives really far from the center urban that has a service that provides mental health support, she doesn't have enough resources to dislocate to these services, even because she doesn't have enough income or because she doesn't have anyone to leave their children with, or because she's afraid that the aggressor is going to find out that she left the house to seek for help. But this is one point. There is another barriers that affect women as well. For example, when women do have services in their location, sometimes they cannot go to the services because the public servant that is there to provide the mental health support, he knows her, he knows their aggressor, he's related to her aggressor, so she gets really afraid to go to the service and be re-victimized or have her words discredited from these public servants, or even though she knows that she's not going to receive qualified attendance. So when we are talking about that, the retaliation and the judgment of these public servants, it's a barrier that make women do not come back to the services because of the kind of support that they receive. This is another point, because the lack of technical training of people who are working, providing the mental health support in these public policies, most of the time they don't have any. So they don't have this gender lens to attend women with a qualified support. So when women go there, they don't want to come back because they know that the person who is going to receive her in that services is not well prepared to help her, to make her break the cycle of violence. So I think these barriers is the most common that we see in our daily basis work. And I think that's why it's so important that we create alternative services that can provide this kind of support to women, like as we do at Mapa do Acolhimento, providing the mental health support through a volunteers network.
Thank you, Anna. That's so, I mean, this kind of trauma, gender-based violence, is so stigmatized in our society, and mostly in rural areas. So I'm going to come back to you and for you to tell us what do we do in terms of gender-based violence healthcare. Thank you, Anna. And I mean, it's obvious that rural communities have practically no healthcare services, and they're desperately needed, right? So, Michelle, can you tell us a little bit of what kind of strategies or innovations low-income countries can develop or implement to increase these services in rural areas? What do you think that we can do? What innovations are out there that we can implement?
Yeah, thanks for that question. I think I can offer a really broad outline of what does and has worked from the work that we've done at Grand Challenges Canada. And I think it has to come with the caveat that, as Rachel and Anna have mentioned, it's very context specific. So if you're working with gender-based violence or intergenerational trauma or settings where there's extreme poverty or ongoing conflict, then the model needs to be adapted to that specific situation. But more broadly, when we're thinking about how do we increase access to a model, I think the first thing is understanding what are the biggest gaps generally across low resource settings. And what we've seen really is that the largest gaps to quality mental health support in rural settings tend to stem from three key challenges, which are: one, a lack of trained professionals, two, limited clinical supervision and mentorship, and three, inadequate integration of monitoring and evaluation to ensure ongoing quality, as well as just an overall dearth of community-based options in these settings. And what we've seen through some of our investments at Grand Challenges Canada is that community health models, where community members are trained to provide mental health support, have shown to have a really significant impact on supporting mental health of their fellow community members. And then digitizing these models can drastically increase the number of individuals who are reached. So in terms of a community health model, this would include clinical supervision of a professional, a licensed professional, but in the day-to-day ongoing support, support is being offered by trained community members in sort of a task shifting effort to enhance access and support. And one example of this is an innovation that we support in Peru, led by Partners in Health, where they're scaling up and digitizing a mental health learning collaborative, which trains community members as health workers to screen for mental health and neuropsychiatric conditions. And then by doing so, they can have a really wide-reaching impact, which is a lot more cost-effective and feasible than having licensed professionals do this part of the work. And then once screened, those who require further professional support would be referred to licensed professionals and supported in attaining that treatment. And in some contexts, the familiarity of trusted and trained community members can also support the uptake of service, which makes it feel a little bit less clinical. And I think much like Anna was saying, it's really important who is providing this service. We see this in our work, particularly among youth, where we've supported some really fantastic models where young people who have lived experience in mental ill health are then trained to support other young people who are experiencing the same thing within their own communities. And the same thing has been done with women who are experiencing gender-based violence or who have experienced gender-based violence, are trained to then provide a service to other members of the community. So these women or these young people can connect on a level of having lived experience and understanding where each other are coming from to create a safer environment for some of this treatment to happen. And then because we work globally at Grand Challenges Canada, we've had a lot of opportunity to learn from contexts across multiple continents that are very often rural, with similar gaps and lessons to be learned. So we've noted that beyond this task shifting approach, where non-professionals are trained, that using digital models are really useful. So an example of combining both of this is an organization we work with in India called the Amar Seva Sangam. And they use an app to connect community rehabilitation workers in very rural geographies to rehabilitation professionals in urban areas who provide supervision and guidance on care. And that's care which these rural populations would otherwise not have access to, just in terms of getting into these areas, over to urban areas as often as they would need for the support that's being given. So these digital task shifting approaches really allow a more rapid rate of scale up to reach larger populations across a variety of geographies and socioeconomic circumstances. And specifically, that includes those who are living in more rural and remote areas. And I know that using digital models in rural settings can often beg the question of access to internet and whether that might impede services. Which is also why investments to support and improve internet access in rural communities can have a really substantial public health benefit. So it's really about setting a foundation for digital access and then working with communities to enhance skill sets of community members. And then finally, stigma toward mental health can also create further disparities to access. And we see this particularly in rural settings. And so coupling these investments in models like this with stigma reduction campaigns is really a useful way to increase buy-in by community members, to have community members actually lead and participate in these models. And I'll end there, but I will add on to a note to something that Anna said in terms of policymakers, that for policymakers out there, that models like these do tend to be suited to public sector support. So really ensuring that governments recognize the importance of mental health and investing in mental health as part of their population health investments is a really crucial component of making this access a reality in these rural settings.
Thank you, Michelle. I think that's so important. I mean, mental health care should become part of our public policy in health, right? And how do we advocate for that? I mean, how do we as organizations advocate for these mental health care? So maybe I'll come back to you, Michelle, with a little bit of thoughts around that. I think we still have a couple of minutes, and we can a lot of interesting things we can still talk about. I wanted to ask Rachel. I mean, building on what you said, do you think that mental health care programs should be built into regular health services, or should these be separated? How do you see this?
Thanks. Yeah, I mean, I think they should be built in. I think that's kind of coming obvious from what all of us are saying. I just want to go on a few things that Michelle and Anna have said, if you don't mind, because I find it really, I think there's some distinctions that are important. There's one side is like the clinical mental health, and then there's the idea of mental wellness. And I think we need to distinguish between these. So I think, as you were talking, Michelle, about some of these digitalized solutions with the availability of a clinically trained person and so on, I think that's really, really important. But I think that we overlook too often the issues of mental wellness and how a community, and that's why I was hoping Gisela could come on, because that's what she was going to talk about. So, and that also, just to show you the limits of remote and digitalized approaches, Gisela is not able to get onto this platform because she's got great connection, but she cannot get onto this platform. So this is the kind of limits that seem like, oh, it's just what she doesn't know how to use a platform. But it's not about that. This is about the barriers that digital approaches put up front. And we see that so clearly. The digital platform is in English. She doesn't speak English. It's not something she's familiar with, and then maybe it just doesn't work also because of the connection. So we have to remember that there are always going to be these indigenous communities that get constantly excluded from sort of digitalized approach. So going on to this idea of wellness, what they did, so Gisela is a women leader from an indigenous community of Lenca in Honduras, outside Retoca, in Retoca, about 14,000 people. And during the the beginning of the COVID pandemic, we were in touch with together to help them to set up their COVID response. We built what we called a Community First COVID-19 roadmap, which gave a very simple 3-step approach to addressing, to organizing, preparing and responding to COVID, which is now being used in communities in over 100 countries worldwide. And translated into many languages. And they used this, and one of the things that they found as they were using it was the importance of doing that mental health, mental wellness work together, that we created networks of women, not only inside Honduras, but also between countries, that were then able to talk about just the reality of being a mother in a COVID pandemic, how to deal with their children, how to deal with their elderly mother that they were worried about, the fact that one of their compañeras had died of COVID and the impact that that had on them. And those sharing spaces that they created and that they had, and some of them were digital platforms, really helped them to get through it and to maintain their leadership in it. And we saw some really critical moments, and Gisela was one person who really led those kind of safe and brave spaces for discussion where these women could share. So that kind of community first model we found has been really important. So this also, when you have this very kind of community first framework, what happens is that communities can come in and inhabit the space that provides to them and make it their own. So inside this framework, it has a lot of community-facing resources. It has uses a strength-based approach rather than a deficit-based approach. Like, what do you have in the community? What strengths do you have? What resources do you have? What assets do you have? And how can we best leverage those to respond? Because it may be that no one comes in a crisis. There may not be a clinical person that can come. There may not be any support from the government, and there may not be a humanitarian organization that turns up and gives you support that you need. So how do we build those? How do we build communities to build that in without becoming dependent on external high-tech, high-level resources? And I think this idea of task shifting, as Michelle mentioned, is a really important one. We call it more task sharing in the communities we work in, because task shifting implies that all the accountability and responsibility is passed to somebody else, which is a bit onerous. But when you talk about task sharing, it gives this idea more of a team-based approach, and that how together we work towards a different way of responding that we can really all contribute to. I'll stop there.
Thank you, Rachel. That's incredible. We have approximately 10 more minutes, so we're going to try to condense our answers in shortly. But I mean, working with communities and making them, how do we build resilient communities, right? Resilient communities to be able to face and to work together in mental health well-being is so important. But so many barriers are still out there. And Anna was talking about the gender vision, the gender vision in healthcare. So what are your thoughts about this? What are your recommendations in how we can address mental health care in gender violence?
I think hearing Rachel and Michelle's, I think there is something that we need to, because when we are talking about gender-based violence, is an urgent and an emergency problem. So we need to deal with this right now because there is women dying at this second. So we need to address this problem in the best way that we can. And that's what we do on Mapa do Acolhimento. But at the same time, we know that this is a government responsibility. So we need to make the government be responsible to provide quality public policies to attend these women, to make them not suffer gender-based violence and make them not die from their aggressors. So when we are talking about what we do about this issue, I think there is we have to understand the timeline of it. So we have this urgent problem that is happening right now, and we need to deal with that. So we need to provide mental health support to women because they need to deal with that situation of violence that they are suffering right now. What Rachel was saying about the pandemic of COVID-19, I was wondering because most of women has to stay inside their houses with their aggressors. So we need to deal with this problem because it was a concrete problem that was happening right now. So we elaborate some materials on how to be safe in your house when you are with your aggressor, like to stay away from knives, to stay away from windows and things like that. Be ready all the time to leave if there's a possibility. So I think we have to deal with this concrete problem. But at the same time, we need to gather communities to fight for public policies that are qualified to deal with this issue and responsibilize the government to deal with this issue, because there is a problem that it needs to be addressed, because in the government we have more safety that this is going to be something that will continue to happen, because when we have solid public policies and the principles of democracy are really states that we know that this is something that is going to keep on going. Because right now we have this network of volunteers, but we know this is something that it's not really going to go to a long-term effect because it's a volunteer work, etc. We need to fight for more public policies that are going to be able to attend these women and make them have this access to mental health support. And that's what we do on NOSAS. We mobilize citizens with mass mobilizations to fight for public policies, to defend democracy. And we know that this is the way that we can reach institutions that are like really grounded and they can attend the issues of the population in all forms, especially on gender-based violence.
That's so important, Dana. Thank you. I mean, we have to work in both sides, right? Working with communities, making communities resilient, and giving them the tools they need to thrive in mental health well-being, but also working with public policies. Michelle, what have you seen any, like, what do you think about how do we advocate for these public policies in mental health?
Yeah, I think what Anna mentioned in terms of public sensitization and education campaigns to really increase demand from the public, especially in democratic settings where the government that has an appetite to listen to citizens. I think that's a first step, is having people who are within the community really engage the government and ensure that there's pressure for the government to make these changes. There's another side to that in terms of feasibility and what governments are able to do with budgets that they have. And I think there's an important aspect of ensuring that that the programs are feasible, cost effective, so that governments will be engaged in continuing on to work with them, as well as engaging governments early on in the issue so that they're seeing firsthand what the issue is and how they can ensure that issue becomes covered. And Rachel, I think we might have lost everybody. But
so we could just have a conversation together.
I'm not sure if you've been able to get
Zella.
Yes.
I could try to put her on. I'm going to call her.
Okay, can you hear me?
Yes, we just can't see you.
Hi.
You're back.
Okay, we had something here. Something happened, but I'm back.
Another example of how digital is difficult.
Okay. Yes, Michelle. Sorry.
Just mentioning that that's another example of how there are issues with digital models of doing things that that need to be worked out.
Okay, thank you so much. I am really, really frustrated that Gisela could not be with us today, because it was so important to listen from the communitarian aspect and point of view of what they're doing in their communities. So I'm really sad she wasn't able to join us, but thank you, Michelle. Thank you, Rachel. Anna's back. Thank you so much. I think we have so many work ahead of us in community mental health. But thank you for the work you're doing, and I hope everybody enjoyed our panel. And I invite everybody to our closing session in a few minutes.
Thank you.
So thank you for being with us.
Thank you so much.
Thank you so much.
Bye.
Bye.